Hello, testing 1, 2. Greetings, everybody. Welcome. Get ready to rumble.
Hi, John, can you hear me?
Yeah, hi, Ahmed. How you doing? Yeah, I can hear you.
Great, I'm just sharing and promote for the webinar.
Oh, let me get my YouTube off. Yes, I can hear you.
Can you mute me?
September we dey now. We dey. No worry. We dey now. We go still play some home match.
Abel, I had to mute you because we're getting some noise, okay?
Good.
Hi, Professor, can you hear me? Professor Kenan?
Can you hear me?
Kenan's here. How you doing?
Can you see me?
Not yet.
I don't know why.
There you go.
mine's
There
better.
you go. How you doing?
Doing well, doing well.
Welcome. Ahmed, are you there, right?
I am
Yeah,
here. So, where is Dr. Al-Ghanemi? I don't see him. I see his name, but I don't see him.
He's coming in now. There he is.
There you are. You know, I don't know your face. I want to introduce you in person.
Hi, dear Professor. No, you can't see me.
So tell me, where is your residence? Where do you live? Which part of Yemen?
In Sana'a.
Sana.
That's the capital,
Sana'a,
right?
You are safe. I read yesterday in the newspaper there was some bombardment problem.
Yeah. A few hours, I think it's 2 hours ago. There was airstrikes beside, around, I mean. It's okay, it's okay.
It's pretty
All
stable
right, I
there.
just wanted to make sure you're safe. That's all.
Alhamdulillah, I'm safe. Alhamdulillah.
Do you treat many war injuries, Ahmed?
Actually, It's in the injured people just go to particular hospitals. Military hospitals that I don't work in yet.
The short is here. People will arrive coming in.
So we have another 5 minutes. Ahmed, tell me about your organization. I would like to learn more. Obviously, this is what you are doing. How is it organized? I know you are in charge, but can you give me just a little tutorial, please?
The Human Dentist Society.
I mean, yeah, and this work that you are doing through your VIP platform and all that.
Actually, Dentist Society is a global society for medical students, mainly, who are interested in neurosurgery around the world. And now it is distributed in more than 60 countries around the world. But each branch in each country has its own, agenda and and plan. So as you know, our country, as it is a developing country and very poor country, that we have no facilities, we have no accessibility to knowledge and something like that. That's these problems encouraged me to get a way to contact with other professors in the other part of the world and start organizing sorry and start organizing with Dr. John Bennett by hosting the most famous and the most prestigious neurosurgery professors around the world. So the main cause to have these webinars is the shortage and the lack of facilities and accessibilities to the knowledge and training in neurosurgery in Yemen. So this is the main reason.
So the president is of the Dundee Society is still my friend Professor
Abdul Sharif.
Salim
Abdurrahman,
Abdul.
sorry, Salim Abdurrahman, yeah, Professor Salim.
You know him?
For sure. And now he, last year
So
he promoted me to be the special assistant to him, globally.
so you know that we started together in Little Rock.
Oh, really
So
amazing.
we worked together for several years in Little Rock under Dr. Al-Mefti, and he then went on to go to St. Louis after that. But we know each other very well. We're very close friends, by the way. It's unknown. It doesn't matter. But what I'm saying is I'm so glad that he developed this network around the world and with you guys, young generation, that he went ahead. And so he was young attending at that time, and I was chief resident. So I do many cases. I did many cases with him. He's a brilliant surgeon. Brilliant. I learned a lot from him.
Great.
He now lives in DC,
He travels a lot now, right?
No, he is in DC at George Washington University Department of Neurosurgery, but he traveled like all of us. He travels all the time, I think.
More importantly, is how you adapt. How'd you adapt to Tennessee? I mean, that is a deep South.
Oh, Tennessee?
Deep South.
It's very interesting. When I finished my training with the Yashar Gilal Mefti, Ali Krisht, all my friends and mentors, Salim, they offered me to stay in Little Rock. But
Okay.
I decided it's time for me for a move out, to. So Rick Boop, I don't know, Rick Boop, Professor Boop, famous pediatric neurosurgeon. He was also one of my mentors at that time. So he asked me to come to Memphis to join the Sam's Murphy Clinic. And that was the best decision I made, because Sam's Murphy Clinic is 112 years old. And the guy who established Sam's Murphy Clinic, his name is Sams, obviously. He is disciple of Cushing. So his second or third resident, first resident of Cushing was Dandy, then it was Cushing. So he came to Memphis, established this clinic and all that. And this clinic is very strong, powerful. It has always leaders of neurosurgery throughout the world. President of WFNS every 7, 8 years comes from my clinic. So yeah.
Love to televise you anytime you want to televise.
Do you know, I mean, you know Dr. Boop, yeah, Dr. Robertson,
Good.
Dr. Foley,
heard of
Kevin Foley. Kevin Foley is our current chairman. He's a father of spinal.
We'd love to televise them. We're
yeah,
gonna start.
so-
We're gonna start now. Excuse me, Doc.
Sure,
We're gonna start
sure.
now. Okay. Bayam, you're gonna moderate, right?
Yes.
Okay. I'm gonna introduce you first. All right, and then you take it from there. You introduce where we have to do. Okay. Here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good morning, and from Miami Beach, this is Dr. John Bennett, home of Neurosurgical TV. We have the pleasure of having a long-standing webinar with Ahmed Ghanemi, a real pioneer in education in the Yemen area. And we have Bayam Sado, who's going to moderate the proceedings. Go ahead. It's over to you, Bayam.
Thank you so much, Dr. Joan, and thanks for the Neurosurgical TV for having us. So hello, everyone. As Dr. Joan introduced me, my name is Bayam Sado. I'm a final year medical student in Saudi Arabia, and I'm the president of the Walter A. Dandy Neurosurgical Society in Saudi Arabia. I am here joined with my colleague and co-host, Dr. Ahmed Al-Ghani, and it's our pleasure to welcome you all to this great webinar, Building the Future Mentorship in Skull-Based Neurosurgery and Empowering Neurosurgeons in the Developing World. We are really honored to be hosting two of the most influential figures in skull-based neurosurgery, Prof. Kenan Arnautovic and Prof. Borba. Before we start, we kindly ask you that if you have any questions for our esteemed speakers, please submit them in the Q&A chat box. We will make sure to address them, inshallah, later on in the presentations. Our first session will be given by the esteemed Prof. Kenan Arnautovic on Chiari I malformation in adults, 20-70 degrees decompression of foramen magnum to achieve complete resection and resolution of syringomyelia and neurological deficits. Prof. Kenan Arnautovic is a senior neurosurgeon at the historic Sims Murphy Clinic in Memphis and a professor of neurosurgery and neurology at the University of Tennessee. He obtained his master's degree in neurosurgery in his alma mater, University of Sarajevo, Bosnia and Herzegovina, and defended his thesis at the J.J. Stormare University in Croatia. His training includes residencies in Sarajevo and the University of Arkansas for medical sciences, followed by a skull-based fellowship under Prof. Osama Al-Mifti, Prof. Ghazi Yashargil, and Prof. Evandaro de Oliveira. He is a double board certified in Europe and the United States. He has published extensively and described original neurosurgical anatomy and techniques, including the suboccipital cavernous sinus, the suboccipital ligament, and the 20-70 degrees Chiari I decompression. He has also co-edited multiple textbooks, and he established the International Neurosurgery Fellowship at Sims Murphy, training more than 40 neurosurgeons worldwide, and has delivered invited lectures on all continents. He is the first vice president of the World Federation of the Neurosurgical Societies and currently sits on multiple editorial boards, including Operative Neurosurgery and World Neurosurgery. He is a member of the World Academy of Neurosurgery, the European Academy of Sciences and Arts, and the Academy of Sciences and Arts of Bosnia and Herzegovina, reflecting his global leadership and lifelong dedication to advancing the field. So, Prof. Arnautovic, the floor is yours.
Thank you very much, Bayam. Very warm. Can you see my screen?
Yes, we can.
But I don't see my screen.
It's just showing Zoom. It's not the presentation.
I'll stop sharing and reshare again. I don't know what's going on.
Yeah, try it again.
Can you see it?
Yeah, keep going.
Yeah.
And now put
Excellent.
it on presentation mode at the bottom. There's a presentation mode.
How is it?
Perfect.
Thank you so much. So, good afternoon, good morning, good evening to, I feel best when I'm surrounded by young neurosurgeons. This is very exciting, to be presenting some of my work that I devoted many years of my career. And I would like to thank Ahmed Al-Ghanemi and Biam, our dear colleagues, for organizing this. I want to just tell you something historically which is not known. This revolution of neurosurgical education through Zoom started about 4 or 5 years ago, around COVID time, when I was the chair of committees at WFNS and Dr. Borba was chair of education committee. And since that time, this has exploded, as you know, and you guys, the new generation, took it to the next level. People like Ahmed and his team in Dende Society, and people like Sameh El Morsi Hassan, and people like Noor, and many other young neurosurgeons who has brought this education to the next level. And please keep up the good work. This is very important, and this is part of a very important mission, and you serve our neurosurgical field very well. And one more thing I want to say also, it's less known. I grew up not far from you guys. I grew up in Khartoum, Sudan, where I went to elementary and middle school. So this part of the world, the Middle East, is always very dear to me and my heart because I spent some of my dear childhood time there. So that's another important thing. So I'm going to talk today about 270 degrees decompression of foramen magnum in resolution of syringomyelia and Chiari malformation in adults. But before, I just want to briefly touch upon, I like to kind of, for people who don't know me well, just to say I'm one of the I guess not very frequent people who belong to several different countries. Obviously, I was born in beautiful city of Sarajevo, and I now practice in Memphis, Tennessee. Sarajevo is one of the most beautiful cities, and I go there several times a year. I finished my first residency there. This is my medical school, and this is my first department of neurosurgery. Nobody can recognize me now from this picture, but that's me, believe it or not. And then I finished my training. I finished my examination, so I'm boarded there and boarded also in Croatia and in Albania. And then I came to United States where I joined Department of Neurosurgery, University of Arkansas. And I was really fortunate there to be involved in the lab for more than 2 years. You can see me here working with another my partner of crime, Dr. Ugur Ture, and Dr. Borba is here. So we're the original three people who worked there for 2 or 3 years and published some articles and developed lifelong friendship. And I love to meet with them around the world throughout the courses and have a good time. So I was also fortunate, and I always like to mention this. We are standing on shoulders of giants. This is my mentor, Professor Al-Mefti, and Professor Yashagil. He just passed away. It's not also known, grandfather of Professor Yashagil, actually grandmother of Professor Yashagil is from Sarajevo. So when he was leaving department, he gave me this picture and he signed, "We are 6th-degree cousins," and he put here that fact. I didn't know that we are cousins, but he did some research. Of course, Professor Krisht, dear friend, and Professor Boop, and then late Professor Oliveira, who came to Little Rock very often, and we spent a long time together. And just a couple more words about Tennessee. It's a deep South state, and I'm here in Memphis, and Memphis is very well known for music. Elvis started his legacy there, but not only Elvis, this is also B.B. King, and a lot of different famous performers, artists, and of course, Memphis Grizzlies, very dear. I go every other week and watch the games and put my Grizzly shirt on, and that's great. And then finally, as I said, our department is 20. I've been 23 years in this department. Our department is 113 years old, established by Dr. Sams. This is our university hospital, and this is our current faculty lineup. Obviously, very, very prominent neurosurgeons, and I'm really honored to be here. So, first of all, let me tell you what is Chiari I malformation. It is very common pathology or findings. I'm not sure, where do we put it? Is it malformation or formation? But it is congenital or acquired. And first it was described by Dr. Chiari back in end of 19th century, 1891, with the displacement of posterior fossa structures 3 to 5 millimeter below the level of foramen magnum. And usually there is this peg-like pointing of the tonsil down, and then obliteration of subarachnoid spaces. The main problem in this malformation is the lack of proper circulation of spinal fluid from craniocervical compartment to the spinal compartment. And usually what happens is there is compression of the spinal cord and the brainstem. There is syrinx that's formed in the cervical spinal cord, which can extend all the way down to thoracic. And then there are a variety of neurological deficits. Usually it presents at age of 41. Cisterna magna is uniformly obliterated. And these are the three people who gave us most initial information. In addition to Hans Chiari, who is from, obviously, Vienna, there was a gentleman, John Cleland, from Glasgow, UK, who did contribution, and also Arnold, who is from Heidelberg, Germany. And one of the things, I want to educate you here and forever take with you, Chiari malformation is not just one simple entity. These are several malformations or several problems that exist in craniocervical junction. So I'm going to be talking today about classic or simple Chiari I malformation. That is that the posterior cranial fossa is small. It cannot accommodate the cerebellum size, and the cerebellum start migrating downwards below the level of the foramen magnum. The secondary Chiari I malformation is malformation that can be resulting from hydrocephalus, from idiopathic intracranial hypertension, pseudotumor, idiopathic intracranial hypotension, and tumor. So this is secondary, and this is not something that I'm going to talk about today. And then there is a complex Chiari I malformation. These are Chiari malformations which are complex and associated with platybasia, basilar invagination, retroflexodontoid, or craniocervical spinal instability. So this malformation needs to be decompressed and stabilized. You need to put screws, you need to decompress, and it is very different from simple or classic Chiari I malformation, where there is absolutely no instability. There is no instability, and it does not need fusion. So please always keep in mind, and this is a board question. In different boards in the world, this will be your question about how to treat different subtypes, if you will. So I did devote a lot of my work on research on this subject, and one of the things that came to me is that this procedure that we created or tried to develop about 20 years ago, 23 years ago, has such a good results that I never planned to have so many patients of Chiari malformation come to my clinic. but they have their blogs, they have their WhatsApp groups, patients that is, and they keep recommending, and they keep coming and being referred. So I was blessed to have a lot of this patient, in addition to a lot of other skull-based problems I deal with. And that was the reason why I published so much, because I think we owe it to our profession. If we have substantial load of certain pathology, substantial number of certain patients, we need to notice, discover, report certain experiences that we had. So I'll just go through some of the dissection slides of mine, just to tell you there are 3 layers of muscles going between skin and subcutaneous tissue. One is superficial layer, trapezius and sternocleidomastoid muscle. The other layer is obviously semispinalis capitis and splenius. This is second layer, and you can see the occipital major or C2 nerve pierces this muscle. And then there is a rich venous plexus between second and third layer, as you can see here, that is located. So when you operate in this area, this is where you will encounter venous bleeding. And then there is a third layer of muscles where I describe 2 triangles. One is superior suboccipital triangle, you can see it here, between rectus posterior major, obliquus and superior and obliquus inferior. And the second is inferior suboccipital triangle between obliquus inferior, splenius cervicis, and semispinalis cervicis. So here is where vertebral artery and surrounding venous sinus lives. And then here you have suboccipital membrane, posterior suboccipital membrane. You can see it here, which has this opening where there is a venous connection between this venous sinus and this deep suboccipital plexus. What I discovered when I was dissecting this area and learning, I discovered that vertebral artery is not surrounded by some venous plexus. It is surrounded by the sinus. It has a membrane, and it has all these venous channels around. And I told that to Dr. Almefti, and he didn't believe. He said, "Prove it to me. Do the cuts in the lab and do the staining and prove it scientifically. You can't just claim something that you don't have proof of." So I went. There was one pathologist, Dr. Muhammad Hussein, who was in Little Rock, and then we did spend a lot of time doing some cuts through this area and doing some staining. This is H&E, and this is Mason trichrome stain, and we proved that this is not any sinus, any plexus. This is a true sinus. And then we also studied all these venous connections between the sinus and the surrounding Batson plexus, marginal sinus, obviously jugular vein, and all that. So what I want also to mention here, that there are 4 segments of the vertebral artery, as you probably know very well from your anatomy classes. And the segment of the vertebral artery that is associated with this surgeries in the craniocervical junction and Chiari I malformation is obviously the 3rd segment, which has vertical part and horizontal part of the vertebral artery. And you can see it here once I cleaned the sinus around it with numerous branches, arterial branches, perforators, and C2 nerve. And then there is also a ring in the foramen of C1, which also mimics cavernous sinus. And there is dural ring, which also proximally delineates the vertebral artery towards the intracranial compartment. So then when I put this cross-section of suboccipital cavernous sinus and this work of Dr. Cavazze, our beloved teacher, we saw that this is very similar, almost identical structures. And you can see here, we also put some schematic drawing, and it granted me appearance on Journal of Neurosurgery cover, which I'm very proud of. The other structures that I studied over time was suboccipital ligament, because whenever I went and operate in this area, I saw this ligament. As you can see it here, these are intraoperative pictures, and it has never been named. They say it's a band, dural band, it's a ligament. So we named it suboccipital ligament, and many times they were saying that this ligament is more developed in Chiari I malformation than in normal patients. So what I did is I harvested it in every Chiari patient that I did over the 2 years period, and I also harvested this ligament on the posterior fossa surgery patients with another pathology, such as tumors and things. And we measured the thickness, the length, the width, and we noticed that there is no difference in size between Chiari malformation and non-Chiari malformation patient in the size and thickness of this ligament. The only difference was this hyaline body that was uniformly found in Chiari malformation, which we don't know why. Why does it exist only in Chiari patients? This is something for you guys to take on and work more on that. So first thing, before I started going about it, I was, my daughter at that time, she's now a plastic surgeon, she was medical student. I charged her to do this very extensive study about all the publications done for approximately 50 years. And what we did is we kind of she took all this publication, tabulated it and all that. And what you can see here that the interest over time about Chiari malformation publishing has skyrocketed and increased over the years. And we identified 145 series. And as you can see here, in the recent 20 years or more than that, 25, the interest is ever growing. The other thing, what nobody publishes, and I don't know why in this meta-analysis, the guys come up with all kinds of publications, but nobody looks in continental publications. So we noticed that all the publications, majority of them coming from the United States, then Great Britain, Italy, etc., and most of them from North America and Europe, very few from Asia and then other countries. And I wonder, is this because Chiari malformation is less frequent in other countries, or the well-developed countries have more opportunity to diagnose them through some developed MRI network and so forth. So this remains to be seen. The other thing is, what we also established that in pediatric population, it is roughly even distribution between male and female. Whereas in adult population, much more common are females, almost 2 to 1. This is a very interesting finding. Why is it more common in females in adult and not in pediatric? So a lot of questions and not good answers. And then roughly the same number of series between adult and pediatric. By the way, you will see here, I'll show, I did about 300 Chiaris so far, and these are, on each slide, I'll show you pre and post-operative, slides. So the other findings that we discovered also in this review is that most common presentation is 41 years of age. So this is the most common presentation of Chiari I malformation in the world, because based on this all published studies that we reviewed. And then also syrinx, very interesting. In pediatric series, syrinx is present only in 40%, whereas in adult series in almost 70%. Why is this difference so significant between pediatric series presentation of syrinx and adult? We don't know. And then what we saw, and what this is a hard fact, what do people around the world, what do neurosurgeons in all countries in the world do for Chiari malformation? So in pediatric series, everybody does posterior fossa decompression, and in adult, same. So everybody does decompression. I'm again talking about simple Chiari I malformation or common Chiari I malformation. And then in adult series, almost everybody gets dural opening, whereas in pediatric, a little bit less frequent. And then in adult series, arachnoid opening 70%, so 2/3 of patients, whereas in pediatric only 50%. And then tonsillar resection is less frequent. So when we look into we looked into postoperative outcomes, and we saw that headaches improvement, syringomyelia improvement, neurological improvement is very good. So with this technique, 75% of patients do well. This is very good, you know, when you have 75% of patients recover neurologically. But there is still room of improvement. And this is what kind of put me thinking, what can we do to improve this outcome from 75% to push to 90, 100%? The other thing also, the most common problem in Chiari I malformation is complication around CSF leak. You can see CSF leak most common, and pseudomeningocele, CSF-related complications, and also wound infection and meningitis. So almost 90% of complications, both in pediatric and adult, are coming from CSF leak or CSF problems. And then also what we found in this meta-analysis is that 11% of studies reported mortality, and that has been also recorded, and no difference between adult and pediatric. So this surgery, this problem has also risks of mortality. So then we developed this technique of 270 degrees decompression. If the problem of Chiari I malformation is fluid transmission between the cranial and spinal segment, you gotta give it the full reestablishment, both coming out from the fourth ventricle through foramen of Magendie and coming out from the foramina of Luschka. So I'll just show you this technique in a minute. The other thing that you need to know for any skull base and any microsurgical procedure, this set of bipolars that Professor Yashagil has developed with progressive size of tips. So you are very precise on the surface, and then goes to the depth of the brain, and different sizes and suction tips, and always using controlled suction. So how do we stop CSF leak? We stop CSF leak by harvesting fat at the beginning of surgery, and this fat we use, I'll show you how we use it at the end. And then I'll show you now just the main tenets of our surgery. This is position, prone position with flexion. This is the size of incision is only about 3 inches. Gel foam powder we use for stopping of bleeding from venous, very efficient mean of stopping of bleeding from venous sinuses. You can see how we apply it here with Perry. And this is this 270 degrees. So important thing is to decompress foramen magnum laterally. You see, it's not important to go high with decompression, but to decompress it laterally. And then it's important to resect this ligament. I'm sorry. This ligament, as you see, has 2 roots. We discovered and described these 2 roots, which are kind of flanking vertebral artery. So you need to divide this ligament as we go laterally. And then we need to drill the posterior 1/5 or 1/6 of the condyle here, so we can have a good access to the Luschka foramina. And you can see here, once we do that and open the arachnoid membrane, as we see here, you can see how we have good access bilaterally to both vertebral arteries, to both picas. Here is foramen of Luschka, and wide decompression of craniocervical junction. And I'll show you here just real quick this operative video. So this is opening, suboccipital decompression completed. This is internal retraction, as Professor Yashagil taught me to do it by slowly displacing the brain tissue over the patty and not using any retractions. And once we open the right and left cerebellomedullary cistern, you can see here all anatomy is in front of you. Pica, lower cranial nerves, vertebral artery, and then here is Luschka. See the spinal fluid coming from Luschka foramen. That's very important because there is no good decompression unless you decompress both. Here I'm showing Luschka, you see. So you have to decompress it widely, and then, of course, open foramen of Magendie. And then at the end, we just coagulate the tips of the tonsils, which are all discarded, and they shrivel up, and you can see here decompression. So what's the result? Obviously, I want to go just disclosure is very important. So we use this bovine pericardium to close the opening. We cut it in triangular cone-like shape. And here is how we secure it to the dura. And you can see at the end, we use some two-sealed watertight closure, but you can never mimic watertight situation because the CSF is released. So there is no enough internal pressure to do reliable testing. So we always put this fat that we harvested at the beginning of surgery to obliterate dead space. And guess what? I'm still waiting for my first Chiari malformation postoperative CSF leak. So this is, I think, very important. So what's the result? This is a patient coming before surgery. You can see severe myelopathy. This is patient coming after decompression to take his stitches. And this is 3 months later coming for checkup. And you can see tremendous improvement in neurological exam with this technique. So we put our results then in this publication, Neurosurgery Clinics of North America. So what we did, one of my goals was to compare my results with this technique with the results that we gained from this meta-analysis. And this was not assessed by me. This is assessed by patients self-reporting of their headaches after the surgery. So as we said, the improvement resolution is almost 80% recorded in adult series, and we got it to 98%, and this is according to self-reported VAS scale that every patient does before and after surgery in my department. The other syringomyelia outcome. So usually in literature, in this meta-analysis, there is approximately 74% in improvement of syringomyelia in adult series reported in the literature. And we got it to 100%. And then for people who are skeptics and say, I'll show you now 20, 30 cases. You can see pre-op and post-op, syringomyelia, pre-op and post-op, pre-op and post-op. Same thing here, another patients. This is another series, pre and post-op. You can see here, this is fat that we put that nicely sealed, and you can see how we reestablish circulation. You see big syrinx pre-op, almost gone post-op. Big syrinx pre-op disappeared post-op. Big syrinx disappeared. Big syrinx disappeared. And then here you can see another series of patients. So what happens with neurological outcome? Neurological outcome is same. It follows the outcome of syrinx resolution. So we were able to push from 77 to 100% improvement of neurological function thanks to this broad decompression. The other thing is, if you do this broad decompression, I'm still waiting for my first recurrence. You know, it's known that Chiari malformation sometimes needs to be operated again. I did not have experience yet in needing to go back. One other thing that we discovered also very interesting, you know, as you saw, 145 series have been reported in the literature. And you can see here that we, for the first time, published that this is disease of obese people. You know, in our series, average BMI is 31. So it's very, very high. You can see here, it is class 1 obesity, according to the WHO scale. And that is also very important findings. And we looked into the height and width of the syrinx, and there was some correlation with obesity with the height and width of syrinxes. So one of the things that I recommend to patients with Chiari I malformation is to lose weight, either to have stomach stapling surgery or to go to weight medications, weight reduction medications. And many patients improve, especially the ones that don't need surgery, because as I said, majority of patients I am following. I'm not operating majority of patients. I'm following just a fraction, operating just a fraction of patients that are symptomatic and need surgery. Majority of patients don't need surgery. And we published also this in Journal of Neurosurgery, and this has been also recorded. And I hope other people are going to report association of increased weight with Chiari I malformation, because I think it's very important in the pathophysiology of this malformation. And here you can see proof for that. You can see here the patient BMI 28, when she increased to BMI 41, you can see here increased syrinx that was not present before, and then after decompression. Another patient, BMI 22, when increased to BMI 32, you see how Chiari malformation developed. Another patient with BMI of 35, mild, relatively mild Chiari malformation, with still some space around brainstem. And look here, started developing syrinx when she went up to 41, and obliteration of craniocervical junction subarachnoid spaces. So I'm keeping myself, as I promised Dr. Ahmed, to 30 to 40 minutes. So I'm exactly at 35 minutes. So this modified 270 degrees circumferential decompression significantly, obviously improves postoperative outcomes, both in syrinx resolution, neurological outcomes, and improvement, Valsalva headache resolution. We also established association of increased BMI with Chiari I malformation. And then using FAT, we were able to eliminate CSF leak as a postoperative complication, at least in 300 patients so far. And then finally, we established that the peak presentation age is 41 years. So at the end, I want to invite you to your neighborhood in December. This will be a big congress, and you're all welcome. There are special benefits for low-income countries attendees and students and young neurosurgeons. So please go to the website, look it up, and try to attend. I thank you very much for your attention, and I'll be very happy to answer any questions.
Thank you so much, Prof, for this excellent presentation and sharing your expertise. So, Dr. Ahmed, we have a few questions. Would you like to ask them to Dr. Arnautovic?
First of all, I would like just to thank Professor for accepting our invitation and being with us tonight. It was really so amazing, and we are so inspired by your excellency and your journey in neurosurgery, and wish to have you many times later. So and personally, I wish I can meet you soon, inshallah. If you permit me more, I would like just to show you the questions in the here.
Please.
Someone asking. Okay, sorry. Professor, can you hear me?
Yeah, I can hear you, but I didn't hear the question.
Well, the question someone asking, according to your experience, how long it has taken for holocord syrinx to resolve?
Excellent question. You know, and I'm preparing this publication. How long? This is a very good question. How long does it take for syrinx to resolve in Chiari I malformation? And I don't know the answer. I'm still looking and analyzing with my fellows. When you operate on Chiari I malformation, and this is non-scientific. When I have a scientific result, I'll come out with it. But non-scientific observation is that the syrinx resolves depending on the length of the syrinx, how long it was present. Now, we frequently don't have MRI before surgery. I mean, we have before surgery, but not like a long-term, 3 months ago and 2 years ago. So it's difficult to establish how long is syrinx. But when we ask the patient, how long do you have headaches? That's how we approximate the probable syrinx symptomatology. Immediately when you do the surgery, and I repeat the MRI in about 2 months after surgery, I like to postoperative changes settle before I do that, the MRI. The syrinx collapses immediately in most of the patients, but not 100%. It is noticeably smaller, and then it takes anyway between 2 months to 1.5 years to completely dissolve. And I have few patients, as I showed you, that don't have 100% resolution. So about 80% of patients have 100% resolution. But there are about 20% of patients that have significant improvement, but still some syrinx. And Dr. Milhorat has one of the great scientists who contributed a lot in this subject. He had published about the central canal septations and I think, and the role of central canal in the spinal cord. But I think if the syrinx has been present for a very long time, some of the septations do occur over time, and in this fraction of patients prevent complete collapse of syrinx. So immediately, 2 months after surgery, you can notice substantial improvement in syrinx, but over time, it further improves in majority of patients. And it may take 1.5 years in my experience.
Well, thank you. Second question. How do you manage the central neuropathic pain of syringomyelia?
Central neuropathic pain is very, very serious problem. And, I think the best management is surgery. And after you decompress, because obviously the pressure of the syrinx is causing this pain, and it is distorting the sensory tracts, spinothalamic tracts, and others in the spinal cord. And by decreasing pressure, it improves. And then we treat them with neuropathic pain medications. As you know, there are a whole slate of those. And I have neurologists in my department. I have pain management specialists. So I work closely with them to determine they act differently on different ages of patients. And I work closely with them to treat them with this neuropathic pain medication. And there is a whole slate of those. Amitriptyline and all kinds of this neuropathic pain medications, modern ones. And
Well, here is another question. What is the most common origin of fat grafts used in the Chiari malformation?
so I use fat graft from the belly, which at least in Memphis everybody has. But I think on this obese patient, there is also option to take them locally from the subcutaneous tissue. But I noticed that fat is not the same. In belly, it's soft fat, which kind of goes and nicely conforms to the space that you need to conform, not only in Chiari, but I also published this prevention of CSF leak in pituitary series.
I'm waiting here.
Hey, Louis, I'm trying to admit you, but you're refusing. It
I'm
says
here, I'm
you're-
here, I'm here.
Oh my God.
Oh, okay. Okay.
So yeah, so I think the fat tissue in the belly is much better than subcutaneous because
Eu falo
subcutaneous
espanhol com
fat
eles.
is a
que
little
é?
bit granulated.
Não, falando espanhol, não tem problema nenhum.
Sorry, there is a question also, an indication for syringo subarachnoid.
So far, I did not have to put shunt because all the syrinx is improved to the point that I did not put the shunt. So I don't have experience with that.
Well, thank you so much, Professor. Professor Luis Borba, are you around, sir?
He's just coming in now. Hello, Louis, welcome.
Hello?
Yeah, Louis, you're on.
I'm here.
Okay.
Oh,
You're
hi.
on, baby, you're on.
I'm in Rio now. We have a hands-on course, cadaveric course. I was there in the lab. Professor Arnautovic, I was listening and watching your presentation. Wonderful as always.
I was
Congratulations, my
telling
friend.
them, I was telling our young colleagues how we started this revolution in this Zoom about 5 years ago when you were chair of the education and I was chair of this coordinator of committees, and how this exploded obviously, and how people like Algenemi and others have put it on the next level with this platform. So I encourage them to go further and keep doing this. This is very important for education.
Yes, of course. Excellent.
Of course,
Excellent.
Dr. John is icon of publication, and thank you for everything you are doing. Well, I guess I'm finishing here. I'm saying goodbye. I will stay tuned to see Dr. Borba's presentation, but I will mute myself and have you enjoyed.
My hair is better than yours. Eh?
Yeah, it's shame how we lost the hair over 30 years.
Hello,
Congratulations, man.
can I ask a question?
Hold on, sir. Wait till after, okay? Okay, so you want to ask Dr. Kenan a question?
Yeah.
Okay, go ahead.
Please.
Go ahead.
So, thank you for excellent talk. I want to ask, how do you know that you have removed enough of foramen magnum or condyle? Like, what is your end point of drilling?
So, as I said, the most important part is to go as wide as possible. And the most important part is to get this transcondylar view as you go up the vertebral artery to see bilateral luschka. So it's usually 1/5 of the condyle that you remove by drilling extradurally, maximally 1/5, maybe 1/6, because when you open the dura and reflect it, you have a good visualization. If you don't remove the part of the posterior condyle in this Chiari surgery or in transcondylar approach, you will be fighting with that bone as you need to dissect it when the tumor is going into the jugular foramen or to follow the lower cranial nerves up. So yeah.
There is a lot of venous plexus in that area once you start going laterally.
Yeah, and as I showed you, the best way to control is this gel foam powder, which you form small marble rounds, marble circles, and then you slowly apply it and slowly push it, and it conforms into the venous channels and stops bleeding. So I use gel foam powder as the best means to do it. You can use fibrin glue, and you can also use Surgicel and other things, but for me, gel foam powder works best.
Recently, I did a case of Chiari, and fourth ventricle outlet was completely blocked, like foramen of Magende. In your experience, how frequently do you encounter that?
It's very often, but I cannot say exactly because it's different types of obstruction. Sometimes it's complete obstruction, sometimes it's obstruction by arachnoid fibers, and sometimes tonsils also, as you saw, contribute to obstruction. So you cannot predict it. That's why you always need to open the dura. That's why you always need to see it open and open it with your scissors as well as Lushka.
Thank you.
Professor Kenan, can I just ask a quick question?
Yes, sir.
For the pre-op investigations in these cases, obviously MRI is a very important modality. There is one sequence described for CSF dynamic flow as sign MRI phase or contrast phase contrast MRI technique.
Good
So
question.
can you please comment on that?
This is opportunity for me to give you preoperative evaluation. First, MRI, very important. You have to look MRI, you have to check axial cuts, T2, sagittal, coronal, see where is the obstruction. That's number one. Number two, you have to do flexion extension studies. Every residents know what's craniocervical instability. You have to rule it in or rule it out. If you have instability, you have to fuse and you have to decompress. If there is no instability, you cannot do any fusions. That's malpractice. So you have to rule out instability. How you rule instability? You do flexion extension x-rays, you do MRI, and with your neuroradiologist, you look into the joints, occipitocervical joint, C0, C1, C1, C2. You look orientation of facets, and you also do CT scan, thin cuts with reconstruction. You have to be absolutely sure not to have instability. But if you have instability, that's different story. That's different approach, and you have. So you have to decide or distinguish if you have instability or not. So every case before decompression, you need to have proper diagnostic. But this sign MRI, I found it not useful. A lot of work, a lot of evaluation, a lot of money spent, and you never know where is it closed, where is it open. So I think the best is direct visualization.
Thank you so much.
All right, I don't want to take time from my friend Dr. Borba, so I'll put you in capable hands of Dr. Borba.
Okay, Payam?
Yes.
Go ahead,
So
Payam.
the next session will be on training in skull-based neurosurgery by the esteemed Prof. Luis Borba. Prof. Luis Borba is a senior neurosurgeon and an adjunct professor of neurosurgery at the Federal University of Paraná, where he also serves as the head of the neurosurgery service at the Hospital de Clínicas and coordinates the neurosurgery program at Hospital Universitario Evangelico de Curitiba. He graduated from the College of Medicine at the Federal University of Pelotas in 1987, completed his master's in neurosurgery at the Federal University at Sao Paulo, and earned his doctorate in clinical surgery at the University of Sao Paulo. He also completed a fellowship in skull-based surgery at the University of Arkansas. Prof. Borba has published more than 60 scientific papers and lectured in over 200 national and international congresses. He also served in multiple leadership positions within the Brazilian Society of Neurosurgery, including the president of the Paraná State Society, president of the Brazilian Congress of Neurosurgery, and the president-elect of the Brazilian Society of Neurosurgery. He is currently the president-elect of the World Federation of Neurosurgical Societies. He has been invited as a coordinator and director of skull-based courses in more than 10 countries across the Americas, Europe, Asia, and the Middle East. Prof. Borba, the floor is yours. Prof. Borba, are you around?
Yeah, I'm here. I was listening this. Don't look like me. No, I'm a neurosurgeon that fighting every day with patients, and I will think to improve myself. In this way, try to help patients around the world and improve the education around the world. But does not mean that what you can do, you can transmit totally to the people. Because the education, the training, everything is much over you. Can you see my screen?
Yes, put it on presentation mode, Louis. Perfect, perfect.
When they ask me to talk about training, I think, what is training? What's education? What is training? What's the difference in the world of a rich country and poor country? Maybe the way that the government see the people and the way that we see the education in the past years, maybe 40 years, 50 years, or the whole humanity. What makes the people different is the education. When you are educated, you improve, you are critical, you can think, you can contest, you make difference. As a neurosurgeon around the world, there are so many differences. But you can try to do with our facilities and improve more and more. I'm from Brazil. Brazil is not a rich country. Some areas are completely different. You have a continental country. You see, the whole Latin America, around 40% or more is Brazil. And we are divided in 5 regions. Here is the Amazon jungle, almost the size of Europe without Russia. See, this is the Amazon, is the jungle. Few people living there, a lot of tribes, and develop in this area is very, very poor. There is one area here we call Central East, when the majority of the food from the whole world is coming from this area. The protein from the beef, the soy, all this agriculture is coming from this area, very productive, extremely productive. This area, a lot of immigrants, especially from Africa, and some that come to this area. But during many, many years and until now, the government in this area does not provide the education for this country, for this area. It makes this very poor in the same country. If you go down here, especially in São Paulo, when the industry is, the country has high level of education. The same happen in the South, when the majority of the people in the South, that is my state, Paraná, Santa Catarina, Rio Grande do Sul, these people came from Europe. A lot of Italians, a lot of Germans, a lot of Ukrainians. In my city, you have in my state, you have 2 cities, they speak Ukrainian. In another city, they speak Germany, but they live in Brazil. If you go down, a lot of Italians, a lot of people. It's make difference. Why you have poor area, you have good area in rich area. The way that they control the country. How they control the country? Education. Education. Don't give education in some areas. In the other one, then the people is more critical that came from developed countries are completely different. I start with this preamble to say what is important in the whole world. We as a neurosurgeon, as a doctor, there is nothing more satisfying to us to do a microsurgical technique and not talk about approach. You receive a patient with tetraparesis in the wheelchair. We do the surgery, remove the tumor using microsurgical technique and preserve the function, and the patient come back to his life. It's as a doctor, it's our mission, not only surgery, as a doctor, it's a mission of a doctor. Nothing is more satisfied to us as a human being when you receive a patient from the poor area of your country, 35 years old, wheelchair, tracheostomy, gastrostomy, during some years, trying to find somebody that can help him. But the people say, no, it's so difficult surgery. I have to spend so much time. This patient has no economically good situation. And his patient go and go and go and come to you in the public hospital. You do the surgery, spend 18 hours in the OR, 18 hours in the OR, and found that the nerves that was impossible to find, that the people say that it was difficult to find the nerves, the artery, using microsurgical technique and dedication for this patient. You can go there, remove, and the patient, after 2-3 months in their recovery, is coming back to his life. It's the satisfaction that you get as a doctor. It is training, but not only training. It's commitment with your profession. It's make you different. When you are medical student, you go to watch a neurosurgery. Sometimes you are very nervous to be in the OR, to be in the operating room, to see that kind of surgery. And you see the guy that is traveling around the brain and looking arteries, looking nerves, and preserve all the structure using microsurgical technique. As a medical student or young doctor, you see, I want to be a neurosurgeon. I want to be there in this area. I want to do this beautiful surgery. I want to see the patient recovery. I want to be in this area. This is the beauty of neurosurgery. But neurosurgery is more than this. More than neurosurgery is a totally dedicated. When you see somebody that go and clip and see one aneurysm, and you clip the aneurysm and save his life, it's make us better as a human being. But time is time. Time is passing. 1996, when I was living in Little Rock, and going back to Brazil, as a young guy, I was thinking that I know everything. I train, I study, I had good teacher, I can do everything. But when you go back home, and with good facilities sometimes, and not so good facilities another time, you feel the difficulty of life. And now I know that more I study, less I know, and more I need to study and dedicate me more and more, independent where you are. There is today no time, there is no space to train in the brain of somebody. You cannot go to the first surgery without know how to do it, to be prepared, and to be ready to everything that can happen. Because this you need to train. Imagine if a pilot start to learn how to manage an airplane in the air. How many planes will crash down a year, a month, a day, a minute? In neurosurgery and in medicine, especially in the surgical area, you need to train. You need to be prepared. And neurosurgery is a single-man surgery. You have your assistant, of course, he help you. But the decision to cut that arachnoid, to coagulate that vessel, to separate the nerves is yours. And your decision has to be based in your knowledge, training, judgment, and commitment to the situation. Nobody has a talent that's coming from somewhere. I like football, see? There is some players, extremely few, maybe 1, 2, 3 in the whole world to have the talent that coming from God, like these 2 Brazilian players. But there are people that make the difference when they are focused, they are dedicated, and they are consistent. You see Lionel Messi? Extremely focused. You see Cristiano Ronaldo? Consistent. 40 years old and still playing in very high level because of his consistency, focus, dedication, and talent. Of course, he has talent. But if you see the videos of Cristiano Ronaldo, 16, 17 years old, he was a good player, but not like he is now and he became during this year. It means that you, independent of the place that you are, you can do the difference to your area, to your people, with training and dedication. For this, we need to have passion. We need to love it to do it. If to stay in the OR 3, 4, 5, 6, 8, 10 hours is a big problem to you, maybe you cannot be a neurosurgeon. If you don't have the determination that you have to be focused and consistent, you cannot be a neurosurgeon. Go to another profession. Maybe you cannot be a doctor. See, this is very important when you decide to do something. This is my first temporal bone dissection. December 24, the night before Christmas. Just me, a temporal bone, and a microscope. I couldn't find the labyrinth. I couldn't find the sigmoid sinus. It means I found nothing. But I see, I need to do, I need to learn, I need to continue. And this is making my life in these 32 years of skull-based training. Not surgery, training. Because I'm learning and training every day. When finish the surgery, I sit and think what I did, how was the surgery, how can I improve, what I did bad, what I can do better, to try to be better every day. This is very important when you have this. In neurosurgery, you need to have an open mind. Always you have new technology, new things that are coming, new approaches. You need to open mind. But you need judgment. And in neurosurgery, you need to take risk. For example, this small ulnar is just under the clinoid. I need to drill the clinoid. I need to open the dural ring. I need to expose the ulnars and clip. It is risk? Of course it is risk. I'm taking risk? Of course I'm taking risk. But this is what I need to save the life of this guy. It's my job. Today in the literature, you can find whatever you want. Every kind of publication, every kind of new approach. You are seeing today endoscopic techniques that are wonderful. But everything that we do is improvement. Imagine this situation here. A small pituitary adenoma, they decide to do the endoscopic approach. Very nice approach, perfect approach. But why to expose and drill bilateral the ICA? If the lesion is in the midline, I need to see the cellar. I don't need to see, I need to imagine and see the bone that is hiding the ICA, but I don't need to expose. And they go there and expose the ICA and rupture. And now this idea to take part of the tongue to close the hole in the ICA. Imagine this situation. And they publish. Big university in America, famous team. This is improvement. Should we follow this just because it's published? Has to be critical. Has to be critical and judgment and learn. A modern approach to olfactory groove meningioma, modern. What's modern? It's new. It's new to come from the nose, remove all the turbinates, make an empty nose here, and just decompress inside the meningioma. When you can do a classical transbasal approach just under the brain and remove the tumor and go home. Just because you have a good video from the nose? You need to learn and think on this. Minimal invasive. Today, everything is minimal invasive. Minimal invasive, minimal invasive. Okay, here. It's a little bit down. Maybe it's not so suitable, but if you come anterior here, good approach, okay? Coming from anterior, you go directly here. Nice. Drill a little bit here. Nice. But what's happened? This patient is from overseas. The guy that did this surgery, performed this surgery, he went to a well-developed country, did a 3 days course, hands-on, endonasal, trans something. He arrived at home Sunday night, and Monday morning he did the surgery. What he learned in the weekend. It means that he's training in the head of somebody. The problem here is not the approach, in minimum acknowledgement. The acknowledgement does not mean that you go to a place and do a course for 2-3 days and come back in the other day. We need to continue training, have a critical view. In this way, you learn and be prepared to do surgery. Or you go to the largest meeting in the world, the American meeting, and see propaganda of the gamma knife for meningioma. Look this tumor. Look the attachment here, very small. You can do surgery and remove this tumor in any part of the world, any country. We just need microsurgical instrument, understand the anatomy, and know where the tumor comes. This is example, very similar tumor. You have a large lesion, and the attachment, see, is the tentorium. Very small attachment, very similar to the case that was in the propaganda of gamma knife leg cell. And you go there and separate the tumor from the cerebellum and go using the arachnoid plane and just separate the vessel and take the tumor out. Simple, but training. And you don't need to do radiation therapy or any kind of crazy disease. You can do in Brazil, can do in Ethiopia, you can do in Yemen, can do in Egypt, can do any part of the world. You have to press and pause. We need to learn that independent of any skull-based approach that you learn in the lab, the best way to travel under the brain are the cisterns. Like in Venice, it's the best way to go to the channels, not go through the buildings. And the cisterns are the most important way to approach and to travel inside the cranium. And the cistern you approach, you see a large aneurysm that you can expose without any skull-based approach, a simple pteryginal approach. In more than 8% of the case, a pteryginal approach or a retrosigmoid approach, you can treat the skull-based lesion in more than 80%. The cisterns of the brain as the best way to treat it. As clip go up. But you don't do anything alone. We need mentorship. We need the people that you believe, that you trust. We need defined priority. And neurosurgery has to be one of your main priority. Maybe not the first one. Always the first one is your family. But neurosurgery has to be a little bit down, not too much. We need partnership, everybody to work together, to exchange experience. In every garden, you can catch one rose, and you build your own garden, but learning a little bit of everyone. Nobody is so perfect, is so good that you learn everything, and nobody is so bad that you don't learn anything. Always you learn something. Sometimes the right way, how to do it, sometimes the way not do it. And you need to be happy. You need to be happy how to do it. That to go to work, to stay long time in the ward, and go there to neurosurgery and see the patient is a problem to you. You are not happy in any profession. You're not doing a good job. The time pass in the OR and you don't feel because you are happy that you are doing it. If you have problems, see, I have to finish the surgery fast because I need to go to somewhere. I need to go to office to see a private patient. I have to do, cannot be a neurosurgeon. You need to commit yourself. As Professor Almefti taught me, give 1 day of your life to try to save the life of the patient. This, I learned a lot for Dr. Almefti, a lot. Neurosurgery, I made it. This quote is the most important thing that I learned from him as a human being that this man is. We need to trust in the people. If you see this guy from China, 1,546 meningiomas of the pretoclavial area, in around 50%, he used the temporal bone, or anterior petrosal, or posterior petrosal, or extend retrocede. It means that petrosal approach is still alive. You need to learn temporal bone. Cannot accept somebody now say that, oh, you don't need to learn temporal bone. I can do everything for the nose. I can do everything for that. If you see somebody, skull-based surgeon, that they say that they do everything for the nose, get out. If they do, they say that they do everything for the temporal bone, get out. We need to learn to travel around the skull base and learn all the approach. This is the way to learn skull base. And you decide the best approach for each situation. Not the approach that you know, is the approach that the patient needs. Today, good educational program, today the knowledge is universal. We are doing this now. You see, we just watched a wonderful presentation of Professor Kenan Arnautović. When you imagine in your life, you have a lecture of Professor Arnautovic or Professor Spetzer, more than 10, 15, 20 minutes in big meetings that you spend a lot of money to go, and sometimes you cannot afford. Now, with this work, I want to congratulate this man that one of his start this kind of education around the world. His name is John Bennett, the tireless John Bennett that helped to change the neurosurgical education around the world. Take on, John, what you did, you continue doing to our generation and for the next generation. But you determine your future. Nobody will do for you. You will decide what is better for you. You cannot cry every day, oh, I learned, I born in Egypt, I born in Brazil, I born in Yemen, I cannot do anything. Of course you can. You can do better, better, better every day. Today you have online, on-site, hands-on simulation models adapt to each area. The online in the pandemic era changed the way we educate. We need, if you can, you need to go and see the guy doing surgery. You need to go and see the guy doing, the 3D is one of, as we are doing here in Rio. We have a course here, I'm in the lab now. We have 20 participants from 10 countries. This is the lab when the guy is training and learning every single day. But nobody will do for you. It's not only the course. The course open your mind. You need to come back home and try. This is placenta that you can get in any hospital in the world. Just talk with the mother. Explain, you get the placenta. It's the best way to train microneurosurgery. Today, you need to plan. You can have a lot of information from the CT, the MRI, the reconstruction, and to plan the neurosurgical approach, the surgical plan. You cannot see the patient, see, in the ward, they say, oh, okay, I do the surgery in 10 minutes. I will be tomorrow morning, 8 o'clock. You see the film, you see the MRI, 7:30, and decide now how to do the approach. We need to think. Learn and study. We need to understand the anatomy. It's the background for everything. The anatomy is in every cadaver in the whole world. Everybody wants to have a nice dissection as Professor Rotton's lab. This is my lab when I was in Little Rock. See? But now you can do in the anatomical department in any country in the world. Of course, if you have technology, you should have everything. It's good, it's better. But the background, the base, is the anatomy. If you know the anatomy, you know where you are, you know where you can go. The course is everything. They are good, really good. But you don't need to go there just to go. Look, this guy here, everybody's watching the dissection around, and this friend here is sleeping. Maybe this guy here that is sleeping will have the certificate in his office. I did a skull-based approach course. But he's not doing to his patient. Maybe he's doing something to his business or to his ego. This cadaver here, anatomy department. This old cadaver that you see, sometimes smell bad. But we are there to learn neurosurgery, to learn anatomy, to save lives. Not to make picture like this that is inject, is beautiful, like that. The simulation with these upsurgeons is a very nice idea that you can train at home. How to put the clip, how to use how to understand this part, to manage your hands. One of the most difficult things when you start to do microsurgery, work in the microscope, is to know where is your hand. You don't know the hands come up, come down, it's coming different direction. There is different models. This is a boot model that they inject in the cadaver. And there is the placenta. This is my lab in Brazil. There is the placenta. We have the cranium, we have the placenta. You can go there and train microsurgery, microanastomosis. See? I will confess here, I need to go back to the lab. Me personally need to go back to train more microanastomosis. Last week, I did one case. I feel so bad. See, I got to it. But if I had going back to the lab and training more, I would be better. I will be back. I will be back. Even after 31 years of neurosurgery. What's happening here? Look here, beautiful lab. You look at this guy here. This guy is in the lab every day. He's training every day. He's my resident. When he has time, he go there and train and learn. What's happening here? Nobody. The lab is empty. Why? The people's worry of another thing. If you don't learn, dedicate, and train, you will not do it. Neurosurgery has to be part of your life. You need to like and love what you're doing. As Brazilian, we love football. Sometimes you cry, sometimes you smile, but it's a sport. I like to eat. I like to meet my friends. I like a good wine. And I also love to do neurosurgery, to be in the OR, to do microsurgery, and to help the people. As a doctor, help somebody and say the word cure is priceless, not only to a neurosurgeon, but to a doctor. Thank you very much, and sorry for the long time. I hope this younger generation that is listening now be ready, that neurosurgery, commitment, dedication, and you can do. If I did, you do, certainly you'll be much better than me. Thank you very much, my friend.
Thank you so much, Prof. Borba. That's actually very inspiring, and it actually fueled our passion more. Thank you so much for your time.
Thank you.
Yeah. You know, honestly, I'm so amazed and astonished about this amazing journey. It is really very inspired for me, and you know, the journey that you talked about, you can say almost looks like mine. You know, as we have, I think, the poorest country in the world. We don't have facilities, we don't have cadavers, we don't have labs for training, we don't have mentors to be trained with, and you can say all the problems that found in multiple countries in the world are just found in our country at the same place. So let me tell you something about my country. Honestly, 90% of neurosurgeons in my country just recognizing subdural hematoma, epidural hematoma, you can see debris fracture, spinal fixation. You can see this is of 90% of neurosurgeons what they are dealing with. Other neurosurgery, you can say skull base, no one do it, or maybe 5% of neurosurgeons, and other types of very difficult approaches in neurosurgery are not found in Yemen. The neurosurgeons that do it are not found in Yemen. So I know this is a crazy talking about that situation, but this is what is really going on in my country, So what do you think about that, sir?
You cannot solve the whole problem, the war. You cannot solve the problem that is happening today in the country, in the political issues, this kind of issues. I don't know what to say to you in this part like that, because Yemen is completely different, the situation that is living now.
Yeah.
See, it's completely different, the situation living now. I cannot say that you need to do a revolution and take people out. I cannot say that you need to meet the people and try to feed. But somebody in the government, somebody in some place, maybe somebody has, I don't know. Somebody trust and believe in the people. Maybe somebody is scared of the people. Or somebody wants to take care of the people.
Yeah.
To move everybody from Yemen outside, to train outside, and to live outside, you cannot do that. try to go in and try to help when the real people don't want, sometimes it's difficult. What I want to say, keep fighting. Not fighting with arms, not fight with gun. Keep fighting that for your people. Better time will come. It's a matter of time. If you need me, I will help to help you.
Thank you. It's a great honor to have this opportunity. By the way, I would like just to know if there is something like WFNS opportunities for training for those who are from the developing countries to get an opportunity for training in another country or something like that. So, is that possible right now? Or how could how could we get it at something like that? Could you? I'm asking about the WFNS opportunities for training in other countries. For those who are from developing countries.
Yeah, you have centers that several centers in the World Federation that they accept the people. See, some of them with scholarship, some of them without scholarship. We need to apply to them, huh? If it's possible to get it. I think this situation is possible to solve, but not to everyone. See, not to everyone. The idea of the World Federation is not to just help with the training and promote immigration. The idea of the World Federation is to help the people to train, and these people come back to his country to help his people, his country, and start to develop a new center there. See, the problem is the majority of the people that go out doesn't want to come back. And this investment is lost because you start to do some centers, try to help some countries. See?
Yeah.
But unfortunately, you cannot get all the money in the world that you need to help everyone. If your country, not say Yemen, say in general, if your country doesn't want, make it more difficult. If you can get some people that you can talk in the countries and try to explain the importance of this training and the people save in the work as a doctor. You see, it will open a lot of doors in Africa, in Latin America, talking with some people from the governments, and some countries understood, another one didn't understand, but maybe you need to try. But Yemen is a little bit different now. Yemen is a little bit difficult now,
It is.
Okay. Please, one question. Don Bennett, just one question. Okay. Okay.
There's one question from Nigeria. Ralph, you want to go ahead from Nigeria?
I need to come back to the lab.
Oh, okay. I'm sorry. Hey, Louis.
Okay, go ahead.
One thing to say about your bald head. My father used to say, grass does not grow on a busy street.
Yeah. Okay. Let's keep working. Keep learning. Who is it from Nigeria? Somebody from Nigeria?
Go ahead, Ralph. Quick. Brahim.
Good evening, Prof. Good evening. From Nigeria, greetings to all my teachers and legends in the neurosurgery. My concern is that in my country, we have a bit of a challenge with lab to train. Most of our training is based on seeing, doing, and performing. And sometimes complex surgery are not junior residents or early fellows are not allowed to partake in complex surgery because of the risk. So I don't know if WFNS can help in creating some labs in different countries where residents can go to practice this microsurgery and in the long run improve the quality of service available to the people. It's all about the people and how best we can help them.
I think in Nigeria has some centers with lab, yeah? Maybe not in your center, but it's another center that they have. One is a center of training of neurosurgery, no?
Lagos, I believe.
Yeah. Maybe let's see, let's contact what you can do to help, but this kind of training is possible. Our plan is the next 3-4 years to increase the number of centers in the special areas. But the problem always is the scholarship. Always the problem is the scholarship. How can get scholarship to the people from the country? For example, we have here in Brazil, the people that's coming from Angola, but the government pay the scholarship to them, that they can come and train and stay longer. See? In other countries, it is difficult to get. This is the problem sometimes. And the World Federation has a limited number of scholarships. That is very limited, because you cannot pay to everyone in the $10,000-$15,000 a year to train, or to $20,000 a year to train. It is the truth. The easiest way is to find in the country one center that you can help to organize something to train. And not only with the cadavers, but the cadaver you have in the anatomy department. Maybe a good relation with the anatomy department, you can go there and get something. Every country is different. In particular, different is make the difference. Okay? Maya.
Okay, Ahmed.
Okay, thank you.
Thank you very much, Louis. Good, very inspirational.
Thank you so much.
Okay, let's keep in touch. Let's keep in touch. Let's keep in touch.
Thank you, Prof.
Ciao, ciao. Thank you. Bye-bye. Thank you.